The first images that arrive in the mind as in a film are not of laboratories or white coats but of hands. Hands that steady a forehead, that press a poultice into a wound, that tie a bandage by lamplight, that pass a small bottle from one palm to another with more hope than certainty. Long before medicine became a recognizable profession, long before hospitals rose as institutions and universities gathered texts beneath vaulted ceilings, healing was woven into the texture of human social life. To understand medicine's origins is to listen to the conversations people had with one another, to feel the tug of obligations, the pressure of scarce resources, the moral calculations made when one life was easier to save than another. This is a story of people attending to one another inside social worlds, not detached observers applying theory, but actors whose choices and customs shaped how bodies were perceived and tended. Imagine a small settlement on the edge of a river plain, its huts clustered under reeds and smoke. A child begins to cough. Someone fetches water heated over a fire. Another crushes bitter leaves between stones, and the elder who has tended births for decades arrives with the calm authority of experience. The elder's knowledge is not written on a tablet or taught in a school. It is an oral map of trials and errors, of seasons and plants, of which spirits to placate and which mixtures soothed a fever for a day. Here, care is social by necessity. Survival depends on kinship, on the obligations of neighbors, on the barter of labor and food. The decision to share a scarce remedy is also a decision about social bonds, who remains within the circle of mutual aid and who does not. This social logic predates cities and texts. In landscapes where hunting and gathering were the daily rhythm, caring practices were intimately bound to the task of keeping the group viable. Wounded hunters were not only suffering individuals, they were contributors to the collective livelihood. A fractured arm could mean fewer hands to gather or to drag a net. Infection in a foot could imperil an entire band's migration. That pragmatic dimension, the calculus of usefulness and mutual dependence, shaped how communities invested in care. Yet that calculation sat beside other motives: compassion, ritual obligation, and the desire to uphold social standing by acting as a provider of comfort. As populations grew and settled into villages and then towns, the practice of healing became more varied and more visibly implicated in social hierarchies. In some places, certain families became associated with healing arts, their knowledge transmitted across generations. In others, religious functionaries, priests, diviners, shamans, took up the role of mediator between the human and the supernatural. Their authority rested not solely on empirical remedies, but on cultural frameworks that explained sickness as a consequence of moral disorder, spirit intrusion, or broken taboos. To be ill was often to be placed in a network of meanings: sin, omen, ancestral displeasure. Treatment therefore required social work as much as it required physical intervention. Rituals that restored social equilibrium were as important as poultices. The tension between bodily remediation and social meaning is a recurring motif across early societies. Consider a communal bath or a medicinal spring. These were sites where bodies were not only cleansed, but where social distinctions could be observed and enforced. Who had access to the best baths, to the most skilled practitioners? Who was permitted to approach certain temples? Access to care was already a matter of status and power. Elites might obtain privileged attention, while the poor and marginalized negotiated remedies in shadowed alleys. The physical geography of a settlement, who lived closest to the temple, who could afford the transport to distant healers, began to map onto health itself. Questions of gender threaded through these arrangements. In many cultures, women held central roles as midwives, herbalists, and keepers of domestic medicine. Their labor combined practical skill and moral authority. Their knowledge was intimate, tacit, and often undervalued by emerging formal institutions. At the same time, as healing became more institutionalized in some societies, male physicians, those who could access written texts, who could apprentice under masters in schools or temples, began to claim prestige. That shift did not abolish women's roles. Rather, it altered the distribution of authority, creating competing domains of expertise. The question that quietly surfaces here, to be answered later across the narrative, is how claims to legitimacy were made and by whom. Was authority rooted in efficacy, in class, in gendered access to literacy and institutions, or in a combination of all these? Consider next the moment when the first codifications of medical knowledge appear. Clay tablets, papyri, palm leaves, and fragments of these archival materials survive as traces, not as complete manuals. They show an uneasy alliance between empirical observation and cultural theology. A prescription might list plants that relieve a symptom and conclude with a ritual formula to placate a god. The coexistence of the practical and the symbolic suggests that early medicine operated in a hybrid register. It healed bodies and restored social meaning simultaneously. In societies where ritual and power were deeply intertwined, the person who could draw on both the practical remedy and the proper ceremonial speech became indispensable. The social position of that person, healer, priest, or both, depended on their ability to navigate these registers. Distance is instructive. When communities traded across valleys or seas, medical ideas moved with them. Along caravan routes and riverways, remedies, theories, and practitioners traveled. A wound dressing known in one valley might reappear, with slight variation, in a distant market town. But the adoption of foreign practices was not automatic. Local customs filtered imported knowledge. Economic power determined which communities could purchase or attract itinerant physicians, while language and cultural compatibility shaped how new ideas were negotiated into existing explanatory frameworks. Medicine, therefore, was a conversation across societies, but one shaped by imbalances of wealth, influence, and prestige. The language of contagion, or rather, the lack of a single language for it, marks a crucial pivot. People noticed that certain ailments clustered in households or among those who worked in particular trades. They developed rules of thumb: avoid certain foods, do not sleep near stagnant water, quarantine those afflicted by particularly feared conditions. These practices were pragmatic attempts to manage risk, yet their implementation revealed social calculation. Who would be isolated? Could a family afford to quarantine its breadwinner? Did a community abandon the sick on the outskirts to protect the many? Here the moral and the practical collide. Decisions about containment were not neutral. They reflected who mattered most within social hierarchies. In some societies, outsiders and lower classes bore the brunt of exclusionary measures. In others, rituals attempted to integrate the suffering back into the community. The way a society chooses to respond to contagion is therefore also a mirror of its values. One of the quiet dramas of these early worlds is the negotiation of meaning between healers and the broader community. Healers depended on reputation. Reputation depended on narrative. A successful cure became a story told and retold, enlarging the healer's authority. A failed intervention could erode trust, prompting accusations of malevolence or incompetence. Social sanction was a real force. In such a fragile economy of trust, the healer had to be not only skilled but socially embedded, a figure who could read kinship networks, who knew whom to enlist when resources were scarce, and who could mobilize ritual to buttress practical measures. This social choreography is often invisible to modern eyes that search for a linear progression from superstition to science. But the emergence of empirical practice did not erase the need for social legitimacy. It reconfigured it. As communities became larger and social divisions more rigid, the organization of care became more institutionalized. Temples, guilds, and later urban hospitals began to concentrate knowledge and resources. These spaces were sites of learning and authority. They drew patients from wide regions, and in doing so, reshaped expectations about who could access specialized care. Wealthy patrons endowed institutions, not merely out of charity but to secure prestige, spiritual benefit, and social control. The poor might find refuge in public dispensaries or charitable hospices, Yet these were often provisional and subject to the politics of generosity. The very act of institutionalizing care created new forms of exclusion, alongside new capacities to treat. The part closes on an uneasy, yet pregnant observation. The practices of early healing were humane and inventive, but also deeply entangled with social relations of power. Healing was not simply a neutral technical skill. It was a social performance performed within unequal theaters. The central theme we carry forward, that medicine mirrors and molds social structure, emerges here plainly. We have seen hands bind a wound because kinship demanded it. We have seen rituals performed to restore honor. We have watched elite patrons fund hospitals for prestige. We have watched the marginalized suffer in silence. The drama now turns. How would the consolidation of knowledge and the rise of formal authority transform these social worlds? What would be gained, and what would be lost as medicine moved toward institutionalization, and eventually toward the claim of scientific objectivity? Questions hang in the air like smoke from the early fires. Who will write the authoritative texts, and who will be excluded from that act of authorship? How will the balance between practical skill and ritual authority be renegotiated as societies grow more complex? What patterns of access and denial will become entrenched, and which will be contested? These questions are not abstract. They are the levers that change lives. We move now from the intimate circles around hearth and river to the institutions and texts where claims of expertise begin to harden into social power. The next scene will follow that hardening, not as an inevitable triumph of knowledge, but as a tangled process in which authority, class, and gender shape the very meaning of what it means to heal. In the quiet corridors of memory, when we think of a healer in the ancient or medieval world, we often imagine a solitary figure tending to a sick neighbor at the edge of a village, or a wandering sage dispensing herbs by the side of a dusty road. Yet, as human societies grew larger and more stratified, the practice of healing gradually took on a new shape, one that was not merely about alleviating suffering, but about who was authorized to speak with certainty about illness, who could claim expertise, and who could command status and resources. The transformation from a medley of local practitioners into a distinct medical profession was neither simple nor inevitable. It was a long and contested process, shaped as much by social hierarchies, education, and institutional power as by knowledge itself. To follow this transformation, we must take the listener first into the great courts and monasteries of the early medieval world. Imagine an illuminated scriptorium in a Christian monastery, or a study in the mighty libraries of Baghdad in the age of the Abbasid Caliphate. Here were texts copied and preserved, translations of Greek and Roman medical works circulated alongside indigenous medical traditions. In these places, healing knowledge began to be codified, debated, and increasingly associated with learned elites. In Western Europe, by the end of the first millennium of the Common Era, centers like the famous Salerno Medical School drew students from across the continent. Its curriculum included not only herbal lore and the practical remedies of folk healers, but also commentaries on classical authors, shaping a distinct body of learning that would become the reference point for later generations. Yet even as this learned tradition grew, the broader world of healing remained diverse and socially textured. In medieval towns and villages, barber surgeons, practical healers who bled, lanced, and set bones, labored at the intersection of necessity and disdain. Their work was essential, but socially ambivalent. Connected to the visceral realities of blood and injury, they were often regarded uneasily by those who aspired to the higher status of the physician schooled in theory and bookish learning. Over years of apprenticeship, sometimes 8 years or more, barber surgeons acquired substantial skill, yet their social standing remained distinct from the physicians who claimed mastery of ancient texts and systems of theory. The hierarchy of healers in this era was not merely about skill, but about access to formal learning and social networks. Those who could read and write Latin, who could study Hippocratic and Galenic texts, who could enroll in the nascent universities of Bologna, Paris, or Montpellier, stood apart from those who learned by doing. The division between learned physicians and practical healers was both intellectual and social. It marked a boundary between those who could interpret and teach medical doctrine and those who executed treatments in workshops and market squares. It was a hierarchy that would only become more pronounced over ensuing centuries. As medieval societies matured into early modern polities, the need for regulation and certification of medical practitioners became increasingly visible. Kings, city councils, and emerging professional guilds began to assert authority over who could call themselves a physician, who could practice surgery, and who must be licensed to sell medicines. In places such as Renaissance Italy, charters and statutes regulated the practice of medicine, defining legal boundaries between different categories of healers and imposing standards of education and conduct. These developments were not simply about protecting the public. They were about consolidating social authority and economic privilege. Whoever controlled access to the label of physician could thereby shape markets, restrict competition, and reinforce class distinctions between learned professionals and lay practitioners. The social contract between medicine and society, the implicit agreement about what healers would do and what society would grant them in return, began to take a more recognizable shape in these centuries. Physicians were accorded status, respect, and a degree of autonomy, and in exchange, society expected them to possess competence, moral integrity, and a commitment to the public good. This unspoken pact was part of what granted the medical profession its growing authority and privilege. Yet the history of professionalization is also a story of tensions and contradictions. The very processes that elevated physicians often marginalized other kinds of healers, women, herbalists, folk practitioners whose knowledge was rooted in community experience, but whose training was not sanctioned by universities or guilds. In many places, women had been central to healing life cycles, attending births, managing household remedies, comforting the sick. As the learned physician became the emblem of medical authority, these gendered histories were often sidelined, their contributions reframed as informal or untrained. This was not simply a matter of ignorance. It was a social reconfiguration of authority, whereby power over interpretation and legitimacy ceded ground to those who controlled formal institutions and texts. By the dawn of the 18th century, the notion of the professional healer was becoming more firmly anchored in social consciousness. The rise of universities and hospitals as institutional centers of medical learning and service provided fertile ground for the consolidation of expertise. Students gathered in lecture halls and anatomical theaters, studying the human body not only through books, but through dissections and observation. The clinic became a site where theory met embodied experience, and where students learned not only what to think but who they were as healers. Knowledge was no longer simply accumulated. It was certified, enacted, and transmitted within structured hierarchies. And yet this consolidation was uneven and contested. Across Europe, and later in the burgeoning cities of the Americas, alternative medical traditions continued to thrive. Herbalists, midwives, and itinerant healers persisted alongside formally trained physicians. In North America in the early 19th century, movements such as the popular health movement challenged the authority of licensed medicine itself, advocating for ordinary people's rights to understand and engage with health care on their own terms. This popular skepticism was deeply rooted in broader political currents that questioned elite privilege and sought to democratize knowledge. These tensions reveal a core dynamic of professionalization. It is not merely the accumulation of knowledge, but the social construction of expertise, legitimacy, and authority. When a guild charter was drawn, when a university required a diploma, when a city magistrate fined an unlicensed healer, these were not neutral administrative acts. They were manifestations of power, about who could speak with authority about illness, who could command resources, and whose voice defined acceptable practice. Professionalization was as much about drawing lines around privilege as it was about advancing scientific understanding. By the mid-19th century, as medicine became ever more entangled with scientific advances and state regulation, physicians came to occupy a prominent position in the social order. Their claim to expert knowledge was buttressed by formal training, professional associations, and licensure laws that restricted entry into the field. The profession claimed autonomy, the ability to set standards for its members, to govern its own conduct, and to define the boundaries of legitimate practice. In return, society expected not only competence but ethical conduct in service to the public good. Yet even as physicians gained status and autonomy, the professional hierarchy continued to shape who received care and whose knowledge counted as valid. The visible markers of authority, diplomas, guild charters, licenses, delineated not just expertise but social standing. Those who lacked access to formal education, whether because of class, gender, or geography, were placed at a structural disadvantage, their knowledge treated as secondary or peripheral. In the closing hours of this phase of history, the listener is left with a question that will echo forward. As medicine becomes institutionalized and professionalized, whose voices will define its purpose and boundaries? Who will be included in the circle of authority, and who will be relegated to its margins? The narrative tension set here, between elite structures of knowledge and the broader social world that must live with their consequences, will return in later scenes, when the stakes of access, privilege, and exclusion become ever more visible in the lives of ordinary people. Thus, the story of medicine's professionalization is not only a tale of knowledge advancing, but of social worlds negotiating power, legitimacy, and moral authority. In the next chapters of this history, these negotiations will take on sharper conflict and broader implications, as illness meets social inequality on a larger stage. When the 19th century dawned across Europe, the roar of steam engines and the glow of factory furnaces transformed village fields and pastoral valleys into sprawling industrial towns. Narrow rows of brick houses sprouted up where once wildflowers had bent in the wind. The cries of children who no longer played in open meadows now echoed through alleyways, for they worked long days beside their parents in cotton mills and foundries. This was a new world, a world of concentrated bodies and concentrated suffering, and it forced a confrontation that earlier societies had only glimpsed in scattered crises. Disease was not merely biological, it was social, bound up with the conditions of life itself. In the heart of that ferment, the German physician Rudolf Virchow stood at a crossroads between science and society. Trained in anatomy and pathology, he could read the human body with precision, revealing alterations in cells that marked the presence of disease. Yet it was an outbreak of typhus in the impoverished region of Upper Silesia that shook his understanding of medicine's task. As he walked through crowded workshops and overburdened tenements, Virchow recognized something staggering. The ravages of illness were magnified not solely by microbes, but by the conditions of life, by hunger, by close quarters, by lack of opportunity. It was not merely a matter of germs circulating through bodies. Entire social orders facilitated their spread. One evening, as he penned his observations upon returning from the field, Virchow would articulate a radical proposition, a proposition that reverberates still in how we understand health and disease. He wrote that if medicine is to fulfill its great task, it must enter political and social life, for the diseases of the populace were, time and again, traceable to defects in society itself. This idea, at once simple and explosive, represented a paradigm shift. In earlier eras, responses to disease had largely centered on remedies, potions, herbs, rituals, or on professional healers delivering interventions one body at a time. The focus was largely individual. In the factories and backstreets of the industrial age, however, the line between individual affliction and collective condition blurred. Crowded workspaces with poor ventilation, inadequate nutrition, absence of sanitation, these factors conspired to make illness widespread and persistent. People did not simply fall ill because of exposure to a pathogen. They fell ill because they had no choice but to live and labor where disease festered. Virchow's insights were not isolated. In early 19th century Paris, the physician and social observer Louis-René Villermé had begun mapping the grim correlation between economic status and mortality rates. By correlating a district's wealth with life expectancy, Villermé laid one of the earliest statistical foundations for what we today call social epidemiology, the idea that health patterns reflect underlying social hierarchies and structural conditions. It was in these crucibles of urban transformation, Manchester, Paris, Berlin, that the modern notion of social medicine took shape. Rather than isolated responses to isolated cases, healthcare became envisioned as an enterprise that must grapple with the life conditions of entire communities. Illness was no longer reducible to individual misfortune, but was deeply entangled with poverty, crowded living, occupational hazard, and the distribution of wealth and power across society. As Virchow pressed his arguments into the public sphere, he also confronted the political realities of his time. Europe in the mid-19th century was a continent of revolution and reform. Across France, Germany, and the Austro-Hungarian lands, movements clamored for constitutional rights, for representation, for the amelioration of class divisions. Virchow staunchly believed that physicians had a social responsibility, not only to treat disease, but to advocate for the conditions that prevented it. Doctors, he insisted, could be the natural advocates of the poor, guiding not only clinical practice but the shaping of policy itself. In this era, the practice of medicine began to expand beyond the narrow walls of clinics and teaching hospitals to encompass statistical inquiry, sanitary reform, and public advocacy. Physicians and social reformers collaborated to document mortality statistics, to map the incidence of disease across neighborhoods, to demonstrate that workers in the most crowded slums died younger and with greater frequency than those in affluent districts. These were not mere numbers. They were testimonies inscribed in the very bodies of the urban poor. Yet the reception of these innovations was uneven because they raised unsettling questions about justice and responsibility. If disease was tied to social conditions, then health became a matter of social concern and perhaps of public obligation. Did governments have a duty to provide water, sanitation, safe housing? Could economic reforms reduce disease? Would improving the well-being of workers improve the health of the whole society? These questions fused medicine with politics, economics, and moral philosophy, and they were fiercely debated in salons, in legislative chambers, and in the pages of reformist journals. As the industrial age advanced into the late 19th and early 20th centuries, these ideas began to solidify into institutional forms. Public health boards were established in growing cities. Sanitary reform became a priority in municipal governance. Germ theory advanced, revealing the specific agents of many infections. But alongside this achievement emerged a recognition that knowledge of causative agents alone could not explain patterns of disease distribution. The distribution was shaped by the conditions in which people lived. Later public health reports, such as the influential Black Report of 1980 in the United Kingdom, would document that even in societies with advanced health services and welfare systems, class inequalities produced wide gaps in life expectancy and disease burden. What emerges from this historical arc is a deepening awareness. Disease is not solely a biological phenomenon, but a social one, a reflection of how societies distribute risk and opportunity, how they value or devalue certain lives, and how power and resources are allocated. The poor do not merely suffer more disease by chance. Their position within social structures, their access to healthy environments, their ability to secure safe working conditions and adequate nourishment. All these shape health outcomes in profound ways. And these patterns are not static. They shift with economic cycles, with policy choices, with the balance of political forces. Yet, in the midst of this expanding understanding lay another tension. Even as social medicine illuminated the connections between society and health, it struggled to translate insight into action. Political reluctance, economic self-interest, and entrenched hierarchies often impeded reforms that might have eased the burden of disease among the most vulnerable. Thus, the story of social medicine's rise is also the story of efforts and resistances, of claims to authority that challenge not only medical practice but social organization itself. By the closing years of the 19th century, medicine had begun to shoulder a broader conceptual burden. It was no longer merely the art of healing individual bodies, but a lens for understanding the conditions that shaped those bodies in the first place. The hospital wards and laboratories of the modern age beckoned, but they now stood in relation, sometimes in tension, sometimes in harmony with the streets, workshops, and tenements from which disease arose. As we move forward into the next chapter of this narrative, we will see how these insights into disease and society intersected with profound political struggles over race, empire, and the uneven reach of medical authority. The lessons of social medicine, that health is woven into the fabric of life itself, will reverberate, sometimes painfully, through the subsequent unfolding of medical history. Across the sweep of human history, the practice of medicine has never existed in a vacuum. It has always reflected the larger power relations, cultural assumptions, and political projects of the societies that shaped it. In the century that followed the industrial revolutions of Europe, another kind of expansion was underway. Vast overseas empires extending their reach across continents and oceans. Alongside merchants, soldiers, and administrators, doctors and medical theories were dispatched into worlds far from Europe's cities. What those physicians carried with them would transform not only the health of colonized peoples, but also the very concepts embedded in medicine. Who counted as human, whose bodies mattered most, and how difference was interpreted in scientific language. To see how medicine became entangled with empire and race, imagine the early years of the British Empire's expansion into South Asia in the mid-18th century. European soldiers and administrators faced unfamiliar diseases, fevers that struck down whole regiments, dysentery that spread through crowded barracks, and the bewildering patterns of tropical maladies that resisted familiar remedies. The survival of the imperial project required responses, and so colonial administrations established medical corps to study disease in these new environments. What began as a practical matter, keeping occupying forces alive, evolved into something broader and more consequential: the systematic categorization of bodies and diseases along racial lines. Western physicians, steeped in classical medical texts and emerging scientific thought, interpreted differences in symptoms and outcomes not merely as environmental or social, but as biologically grounded racial distinctions. This was not an innocent scientific judgment, for it conferred authority on certain bodies while marginalizing others. Similarly, in the sprawling web of the French Empire in Africa and Southeast Asia, medicine was wielded as both a tool of colonial control and a marker of cultural hierarchy. Hospitals and dispensaries served dual purposes. They treated disease, yes, but they also became sites where colonial authority was asserted and where indigenous knowledge was displaced or devalued. European administrators often viewed local healing practices as primitive or superstitious, even when they had effectively sustained communities for generations. By replacing local modalities with Western protocols, colonial medicine reshaped local social landscapes and asserted a new hierarchy of expertise. At the same time, the framing of race in medicine was not confined to distant colonies. Within Europe and in settler states such as the United States, medical authorities began to code racial difference into the very anatomy of disease. Textbooks taught that certain races were predisposed to particular ailments, or that they experienced pain differently, ideas that today are discredited, but which held real consequences for patients, treatment, and dignity. In North America in particular, the legacy of this thinking would reverberate into the modern era, contributing to deep mistrust of medical institutions among marginalized communities whose lived experience included ethical abuses and structural neglect. A mistrust illuminated powerfully in contemporary debates about public health campaigns and vaccine uptake. The intertwined histories of medicine and empire also reveal how scientific authority was deployed to justify intrusive interventions in colonized bodies. In the late 19th and early 20th centuries, public health measures, mass inoculations, forced quarantines, and segregated hospitals were often justified in the name of civilizing missions. Colonial officials portrayed these interventions as benevolent, even humanitarian, while obscuring the coercive power that underlay them. Diseases such as sleeping sickness and leprosy were not only biological threats in the eyes of empire, they became symbols of supposed backwardness, and controlling them became part of asserting political dominance. Yet the story is not one of passive acceptance. Indigenous peoples did not simply receive colonial medicine. They engaged with it, negotiated it, adapted it, resisted it. In some regions, local healers incorporated introduced treatments into existing practice, creating hybrid approaches that blended botanical knowledge with imported techniques. In others, communities articulated forms of resistance, challenging both the legitimacy of colonial authority and its scientific claims. These responses remind us that medicine under empire was not a monolith, but a contested field of encounter, shaped by power but also by agency. The politics of race and health extended back to the metropole as well. In medical schools and scientific communities in Europe and North America, debates about race were not only about distant subjects, but about who belonged within the structures of medical professional life. Curricula in 19th century medical schools often included racialized theories that reinforced social hierarchies, bolstering assumptions about European superiority and justifying exclusion from professional ranks for students of color. These educational foundations had long-lasting effects, shaping who could enter the profession and whose health was prioritized. By the early 20th century, the nexus of race, empire, and medicine had produced deeply entangled legacies. On one hand, colonial medical campaigns brought interventions, vaccination, sanitation projects, and the establishment of health services that reduced mortality from certain infectious diseases. On the other hand, these same systems often reproduced inequalities, privileging the health of colonial settlers and administrative personnel over that of local populations, and all too frequently dismissing indigenous knowledge as inferior. The result was a landscape in which health outcomes were not only uneven, but imbued with symbols of social worth and belonging. Reflecting on this complex history, it becomes clear that medicine did not merely travel with empire as a neutral tool. It was interwoven with the ideological fabric of colonial power. Race became a lens through which bodies were interpreted, classified, and valued. Local traditions of care were reshaped or erased in the service of broader political agendas, and the definitions of normal and pathological were constructed in ways that reinforced existing hierarchies. As the 20th century unfolded, these legacies continued to shape health systems and experiences. Movements for decolonization, for civil rights, and for broader social justice did not separate their struggle for political autonomy from demands for health equity and respect for cultural difference. In many newly independent states, post-colonial governments sought to reframe public health on terms that acknowledged both scientific advances and indigenous contexts, even as resource limitations and global inequalities posed ongoing challenges. Thus, the politics of race and empire in the history of medicine holds a mirror up to the larger story of modernity itself, a story in which scientific authority and social hierarchies were mutually constitutive, and in which the meanings attached to bodies and diseases reflected not only biology but power, identity, and human dignity. In the next stages of this narrative, we will follow how these entanglements of race, authority, and health surfaced in the shaping of institutions such as hospitals, insurance systems, and the very promises of universal care, revealing once again that medicine's history is inseparable from the history of society. The silhouette of a hospital rising against a gray sky can look like a beacon of hope, yet its meaning has not always been universal or the same for everyone who stood before its doors. In fact, the way that hospitals evolved, the meanings attached to them, and the systems developed to pay for care reveal how class, wealth, and social position have shaped who gets help and on what terms. Where once healing was embedded in households and community customs, by the turn of the long 19th century, medicine had been institutionalized into large facilities with corridors, wards, clinicians in uniforms, and a language of science that carried authority. But behind these architectural and organizational forms lay deep and often invisible negotiations, political, economic, and moral, about who such places were for, who could afford them, and who would be left at the margins. Long before the modern hospital became a familiar institution, places for caring for the sick were diverse. In the medieval world, monasteries and charitable hospices offered shelter and rudimentary care to the needy, poor travelers, and the sick alike. These spaces were as much about almsgiving and hospitality as about curing disease. They bore witness to a social order that bound care to moral duty and religious generosity. With urbanization and population growth across Europe, institutions dedicated to care multiplied, from facilities attached to cathedral complexes to independent shelters supported by guilds and benefactors. Some chroniclers in 12th century Europe noted that these early hospitals served not only the destitute, but also those without family support, reflecting a social logic in which care was tied to community obligation as much as healing. Yet by the 18th and 19th centuries, as cities swelled with industrial workers, and as medicine became more scientific, the shape and purpose of hospitals were transformed. No longer solely charitable refuges, they became sites of medical intervention, laboratories of practice and instruction. In the growing metropoles of Europe, hospitals acquired wards for surgical patients, rooms for observation, and spaces where students could apprentice and learn. In many cases, the wealthy still received treatment in their homes, attended by physicians they could retain. The poor increasingly sought care in hospitals when they had no other recourse. This divergence laid bare a stark truth. Access to institutional care was conditioned by class position and economic means. The transition to modern healthcare systems in the 20th century widened these questions rather than resolved them. Across Europe, local and national governments experimented with systems designed to make medical care more broadly available. Insurance schemes arose, some linked to employment, others mandated by law, with the aim of reducing the burden of out-of-pocket payments for workers and their families. In the United Kingdom, for example, the early decades of the century saw the state assume a growing role in financing health services and paying practitioners, so that working men, women, and children could access treatment that once had been accessible only to wealthier classes. But expanded access did not mean that all patients suddenly stood on equal footing. Historians note that even where services were extended to many, inequalities persisted in what care was available and how it was delivered. New medical services were sometimes limited to particular groups, only primary care, or care for specific conditions, and did not always guarantee a uniform standard of quality. In some places, the poor received only basic services, while those with means could elect additional resources, private rooms, or access to specialists. Thus, The very systems designed to include more people also carried the imprint of social stratification. A parallel history unfolded in systems where insurance was tied to employment or private arrangements, such as in the United States. There, much of the 20th century saw debates about whether health insurance should be a matter of individual responsibility, employer provision, or public obligation. Trade unions and worker organizations in the early decades of the century advocated for protections against loss of earnings due to sickness and for care to be available when it was needed. By the 1920s and early 1930s, committees of physicians and public advocates were studying the rising costs of hospital care and recommending broader adoption of health insurance, not as a luxury, but as a bulwark against financial ruin caused by illness. In this period, hospitals themselves became embedded in broader economic and political debates. Were they primarily market institutions, funded by patients or insurers who could pay? Or should they be public goods, financed through collective arrangements so that financial incapacity did not bar entry? These questions were neither abstract nor academic. Families facing sudden medical crises learned sharply that ability to pay shaped not only the timing of care, but often its quality and outcomes. Research in recent decades confirms that even with insurance expansion, socioeconomic status remains a significant determinant of access to health services, because economic gradients persist in how care is delivered and in the distribution of healthcare infrastructure. Across Europe in the mid-century decades, nations experimented with different models. Some, like the National Health Service approach, financed care primarily through general taxation and promised free access at the point of need. Others developed social health insurance systems where contributions from workers and employers sustained care. Still others allowed private insurance markets to coexist with public options. Importantly, outcomes varied, and unequal access persisted in different forms, shaped by details of how services were organized, how vulnerable groups were protected from charges, and how resources were distributed geographically. In many regions, rural populations, ethnic minorities, and the lowest income groups continued to face obstacles to effective access. Within these structural dynamics, the meaning of hospitals shifted again. No longer primarily charitable refuges or places associated only with the indigent, they became centers of high-technology care, with imaging machines, operating theaters, specialists trained in advanced procedures. But these advancements also introduced new barriers. The cost of cutting-edge treatments, the complexity of health systems, and the necessity of insurance or state support meant that class disparities in access could deepen even as overall capacity increased. In some societies, waiting lists for procedures in publicly funded systems became a marker of access inequity, prompting those who could afford private care to seek alternate routes. An insight that resonates with current policy debates about how best to balance universality with quality and choice. Embedded in these institutional evolutions were human stories, families negotiating urgent needs, workers fearing loss of income due to illness, and communities advocating for broader provisions. The experience of coverage, whether through charity, insurance schemes, employer plans, or state systems, shaped how individuals related to health and to the very idea of care as a right or as a commodity. In some nations, the expansion of services was heralded as a moral achievement, a concrete expression of social solidarity. In others, it invoked contested debates about individual responsibility, taxation, and the role of the state. Across these perspectives emerges a profound continuity with earlier eras. Who gets care, under what conditions, and with what social support, has always reflected deeper social arrangements. Hospitals, insurance, and systems of access are not merely functional devices. They are social artifacts, shaped by what a society values, whom it chooses to protect, and how it allocates responsibility for vulnerability. They reveal that the question of access to healthcare is as much about social justice and collective responsibility as it is about medical science. At the close of this segment of our story, we confront questions that will carry forward. Can societies organize care in a way that diminishes class disparities without eroding quality? How do the meanings of care shift when it becomes subject to bureaucratic procedures and economic calculations? And how do individuals and communities negotiate systems in which their humanity and dignity are at stake? These tensions will follow us into the next chapter, where movements for equity and participation reshaped not only institutions, but also the very expectations people held about what medicine could and should be. In the long arc of modern medical history, there are moments when the tides of social aspiration and institutional inertia collide, sending ripples through the lives of countless people. These are moments when ordinary citizens, health workers, families, and communities step beyond passive suffering, taking collective action to challenge not only unjust conditions, but the policies and power structures that produced them. The story of medicine is not only a tale of laboratories and hospitals, but also of protest and policy, of movements that insisted health and access to care are not privileges for the few, but rights that must be fought for together. In the mid-20th century, in the wake of the horrors and upheavals of global conflict, civil rights movements across the world pressed with renewed urgency on social inequalities that reached into every institution of life, including medicine. In the United States, racial segregation in healthcare was not a relic of distant history, but a lived reality well into the 1940s and 1950s, when hospitals and medical societies systematically excluded Black patients and practitioners. In response, physicians, nurses, and activists, Black and white, joined forces in what became known as the medical civil rights movement. They picketed conventions, challenged discriminatory hospital construction funds, and demanded that the American Medical Association end segregation in its policies and local chapters. Physicians such as John Holloman Jr. and Walter Lear organized national protests in the early 1960s, bringing medical justice into the larger struggle for civil rights. These campaigns were not only about access to treatment, they were about belonging and dignity. Hospitals, long seen as bastions of scientific authority and orderly care, were also places where racial hierarchies were maintained in practice, where separate wards and separate treatment reflected broader systems of discrimination. Community organizations, churches, and visiting nurse associations worked in tandem with reformers to establish programs aimed at maternal and infant health among marginalized populations, reaching often where official provision had been absent or discriminatory. Parallel movements emerged in other parts of the world, shaped by local histories, but connected by common themes of justice and equity. In the mid-20th century, newly decolonized nations and international bodies articulated visions of health as a universal right. Delegates at the 1978 Alma-Ata Conference, a gathering convened by the World Health Organization and UNICEF, issued a declaration that articulated something both radical and humane: that health is a fundamental human right, and that primary health care should be the pathway to achieving health for all. This idea extended beyond mere provision of services to encompass social, economic, and political determinants of well-being, the conditions of life that shape vulnerability as much as medical intervention itself. Out of the momentum of Alma-Ata grew a constellation of grassroots initiatives. In 2000, representatives from more than 90 countries met in Bangladesh to found the People's Health Movement, a global network of activists, scholars, and community organizations committed to realizing the promises first articulated at Alma-Ata. What tied these efforts together was a conviction that health inequities were not inevitable consequences of biology or economics alone, but were rooted in structural injustices such as poverty, exploitation, and exclusion. issues that could only be addressed through collective action that connected local struggles with global advocacy. Such movements were not limited to geographically distant arenas. They emerged within advanced industrial societies as well. During the late 20th century, the disability rights movement in the United States staged one of the longest and most determined protests in federal history. In the spring of 1977, activists with disabilities occupied federal offices, demanding enforcement of civil rights protections and access to services guaranteed under a landmark rehabilitation law. The sit-in lasted nearly 28 days, sustained through mutual aid and solidarity. Volunteers from diverse political backgrounds delivered food, helped preserve critical medications in makeshift refrigeration systems, and stood firm against bureaucratic resistance until concrete policy changes were achieved. In the 1980s and 90s, the emergence of the HIV/AIDS pandemic catalyzed a new wave of activism that transformed public perception and health policy. Grassroots organizations such as ACT UP, the AIDS Coalition to Unleash Power, mobilized in cities across the United States and beyond to confront governmental neglect, pharmaceutical inaction, and the stigma that compounded suffering. Their tactics ranged from dramatic demonstrations outside government buildings and pharmaceutical headquarters to sustained engagement with clinical researchers and policymakers. These activists were not merely demands on the margins. They changed the conversation about access to treatment, research priorities, and patient advocacy within medicine itself. The trajectory of these movements reveals an important pattern. Policy often follows protest, but the struggle over what policy should look like reflects deeper conflicts over values and who gets to define the terms of care. In some nations, campaigns for universal coverage, anchored in the idea that health should not be contingent on employment, wealth, or social standing, became central to broader social debates. For example, in the United States, the campaign for some form of universal, government-funded health care stretches back over a century. Reformers in the early 20th century, inspired by labor and social movements in Europe, pressed for protections that would prevent sickness from plunging families into financial ruin. Internationally, the framing of health as a human right took on legal and moral force after the Second World War. The Universal Declaration of Human Rights and subsequent international covenants articulated the idea that every person has the right to the highest attainable standard of physical and mental health. Advocates used this evolving human rights framework to challenge discriminatory practices and to argue that states have obligations not merely to respect life and liberty, but to protect and fulfill health through policies that ensure access, reduce inequalities, and address underlying determinants of disease. By the early 21st century, the struggle for health equity had branched into multiple arenas: community organizing, global networks, policy advocacy, and legal frameworks. But the thread that binds them remains the conviction that health is not simply a medical commodity, but a social good rooted in justice. In spaces from neighborhood clinics to international assemblies, movements have insisted that inequities in care reflect social choices, and have worked to reshape those choices into policies that emphasize participation, dignity, and shared responsibility. And yet, as this part of our story closes, we see that the work of protest and policy is ongoing, not concluded. New challenges arise in technology, in economic inequality, in algorithmic decision-making, and with them new movements form, demanding that the promise of equitable health not be forgotten in the speed of innovation or the inertia of entrenched interests. The stories of protest and policy remind us that medicine's purpose cannot be separated from the social values that guide it, and that collective action has been, and will continue to be, a vital force in shaping what health equity means in each age. Next, our narrative will follow how epidemiological knowledge and demographic data deepened understanding of structural determinants, making visible patterns of inequality, not only in access, but in the very burden of disease across communities and classes. A single street in a single neighborhood can sometimes tell a larger truth. Picture a narrow lane in a dense quarter of a city, the clatter of carts, laundry hung between buildings like flags, a row of pumps where neighbors meet and argue over prices and gossip. When bodies in that lane fell sick one summer, the pattern was not random. It traced networks of water, work, and poverty. The physician who knelt in that lane with a notebook and a rudimentary map did something new. He treated not only individual patients but the geography of illness itself. That moment, the decision to map disease, to count and to compare, is one of the foundations of modern epidemiology, and it opened a way of seeing that would gradually transform medicine from bedside craft to population science. Epidemiology emerged as both method and imagination. Its pioneers combined close observation with numerical comparison. They counted deaths, recorded where they lived, and asked how risks varied across places, occupations, and social groups. Mapping provided a visual argument, tables supplied a moral one. When patterns appeared, more deaths in one neighborhood than another, higher rates of illness among certain trades, those patterns posed questions that could not be answered by looking at single bodies alone. Why did some communities live markedly shorter and sicker lives than others? Were the differences due solely to chance, to inherited frailty, to germs, or to the ways that society arranged people's lives? Those questions sent epidemiologists into streets, factories, and households to gather data that could pull the causes of ill health out of the realm of anecdote and into the language of evidence. The rise of statistical thinking in the 19th century was crucial. Physicians and reformers learned to use rates, ratios, and comparative tables to reveal disparities that otherwise remained invisible. In a number of European cities, systematic registration of births, deaths, and occupations became a public task. These records supplied the raw material for an emergent science of population health. The result was a radical reframing. Disease could be described not only as a misplaced event inside a body, but as patterned across social structures, by income, by occupation, by housing, by race and gender. The data made inequality legible. Once legible, inequality could be debated, measured, and possibly addressed. Yet data are not self-explanatory. The production of epidemiological knowledge has always entailed choices about what to count, whose voices to include, and which categories to use. Early studies sometimes focused on proximate risk factors, contaminated water, poor sanitation, specific occupational exposures, and those insights led to concrete interventions: clean water systems, waste removal, safer factories. These were enormous public health victories, and they revealed how social investment in infrastructure could dramatically reduce infectious disease. At the same time, counting the proximate cause was rarely sufficient to explain why certain populations remained disadvantaged. To understand those enduring differences required a second, deeper layer of analysis: the structural conditions that shape exposure and vulnerability in the first place. The notion of structural determinants of health directs attention to the social, economic, and political mechanisms that distribute advantage and harm across populations. Through the 20th century, successive reports and investigations sharpened this insight. One representative case came in the late 20th century in a country that had created a comprehensive welfare state. An official inquiry documented that even with broad access to medical services, the poorest groups still experienced mortality and morbidity rates far worse than their wealthier counterparts. That finding shattered a complacent assumption that expanding services alone would erase health gaps, and instead emphasized that economic inequality, education, housing, and working conditions drive health outcomes as decisively as clinical care. The study's blunt conclusion, that class structured the distribution of life chances itself, forced policymakers and clinicians to consider social reform alongside biomedical intervention. In the new millennium, global institutions and scholars refined and popularized a language to describe these mechanisms. The World Health Organization's Commission on the Social Determinants of Health set out, in a landmark report published in 2008, a three-part program: improve daily living conditions, address the unequal distribution of power and resources, and generate better evidence and measurement to track progress. The Commission articulated what many local investigators had already intuited: that health inequities are unjust, avoidable, and rooted in social arrangements that produce differential exposure to risk across the life course. This international framing mattered because it turned a cluster of disciplinary findings into a political program, an argument that health policy must extend beyond clinics and laboratories and into taxation, education, housing, and labor rights. One of the most influential voices in translating these ideas into policy language was a public health scholar who led a major review on health inequalities in a high-income country in 2010. His synthesis showed that life expectancy and years lived in good health were strongly patterned by social position. The poorest experience substantially shorter lives and many fewer healthy years than those higher up the social gradient. The review argued for a comprehensive strategy that would tackle early childhood development, fair employment, minimum income, and a healthy environment, explicitly addressing the social gradient in health rather than focusing solely on the worst off. This emphasis altered the conversation. It suggested that social justice in health required action across the entire distribution of society, not only targeted remedies for a few. The history of epidemiology, therefore, becomes a history of deepening explanation. Early work exposed proximate causes and enabled life-saving interventions. Think of clean water and vaccines. Later work asked why some populations faced greater exposure to those proximate risks, and finally why societies permitted such distributions of risk to persist. Structural determinants, the webs of policy, economy, and culture that create social stratification, turned scientific attention toward mechanisms that were political as well as technical. An epidemiology that recognizes structure asks uncomfortable but vital questions. Who benefits from the existing organization of work and housing? How do policy choices around wages, taxation, and land use translate into risk gradients for disease? Which populations are systematically deprived of the resources that prevent illness? Methodologically, this expansion required new tools and collaborations. Population health research blended quantitative mapping and statistical modeling with qualitative studies that probed lived experience. Geographical information systems traced the overlap of pollution sources, transit routes, and health outcomes. Longitudinal cohort studies followed people across decades to see how childhood conditions shaped adult disease. At the same time, community-based participatory research insisted that those most affected by inequities should have a voice in how studies are designed and how data are interpreted. Thus, epidemiology became not only a science of numbers but a practice of accountability, a way of generating evidence that could be used to hold institutions to account. See also public health practice literature. The politics of evidence is worth naming bluntly. Data can illuminate injustice, but it can also be used to rationalize inaction. Statistics may show disparities that are then attributed to cultural failure or genetic destiny unless the structural context is acknowledged. The moral charge of epidemiology lies in its capacity to translate patterns into explanations that point toward remedy. When researchers document that life expectancy differs by a decade across a single city according to postcode, they produce not merely a lament but a mandate. The pattern is an outcome of political choices and thus can be remade by different political choices. Modern crises have made these stakes painfully visible. Global pandemics, environmental disasters, and economic shocks expose how social structures amplify harm. When a novel pathogen spreads, it does so through the pathways of inequality, overcrowded housing, precarious employment that cannot be abandoned without losing wages, and health systems fragmented by funding shortfalls. The epidemiological record of such events is stark. Vulnerability and exposure are patterned by race, class, and place, and the data compel the conclusion that disease does not strike societies uniformly. The lesson is both pragmatic and ethical. Effective public health requires attending to the social determinants that place people at differential risk, and justice requires confronting the inequalities that render some lives expendable in practice, if not in principle. As this segment of our narrative draws to an interim close, the reader should hold two complementary impressions. First, the practice of counting and mapping disease, from the clustering of cholera deaths around a single pump, to the national registers and international reports of the later centuries, a transformed medicine's gaze from the individual bedside to the social landscape. Second, the fuller story of health demanded moving past proximate causes to structural explanations, the political and economic architectures that fashion exposure, vulnerability, and resilience. The consequence is a discipline that is scientific and moral at once, calling upon practitioners not only to diagnose and treat, but also to reckon with the larger arrangements that make some populations sicker than others. The next part of our tale will follow how those arrangements were contested in institutions and in policy, in hospitals, insurance schemes, and the civic struggles over what care should look like in a just society. In a sunlit room, a scholar leafs through a battered notebook filled with lists of names, dates, and diagrams, not merely numbers on a page, but stories of human struggle and resilience. These records are more than academic relics. They are testimony to the many voices that shape the past we have traced, from early healers tending bodies beside riverbanks to 20th century advocates insisting health must be a right and not a privilege. As memory and medicine intersect here, we are compelled to ask not only what has been learned, but what must be carried forward. For medicine's future, the way societies choose to care for their most vulnerable is deeply marked by the memories of struggle, protest, and shifting policies that brought us to this moment. The history of health equity, like the history of medicine itself, unfolded through distinct stages of awareness and action. In the earliest years of systematic inquiry into health, measures to improve sanitation and living conditions emerged in the long 19th century in response to appalling mortality in crowded industrial towns. As the world progressed into the middle of the 20th century, the language of health disparity, health equality, and health equity took shape in public health discourse and social inquiry. The formal study of health equity became a recognized domain only a century ago, but its roots reach back into a lineage of thought that saw health as both an individual outcome and a collective condition shaped by society's architecture. A turning point came in the mid-20th century with the founding of international institutions that anchored the idea of health as a fundamental human right. After the Second World War, the Constitution of the World Health Organization and the Universal Declaration of Human Rights articulated a moral framework that transcended national borders, asserting that every person should have the opportunity to attain the highest standard of health attainable. This Fram not sign ing did not emerge spontaneously. It flowed from earlier recognition that disease patterns reflected unequal access to conditions of life, such as clean water, education, and humane labor. These insights into how environments and social conditions shape well-being are now formalized in the concept of social determinants of health, the economic, political, and social fabrics that shape the conditions into which people are born, live, work, and age. These determinants, education opportunity, decent housing, fair wages, and safe neighborhoods, are far more than background context. They are foundational drivers of health outcomes. The World Health Organization observes that adjusting these determinants not only prevents illness, but also advances the justice of health itself. by enabling each person to live a life with dignity and opportunity. When we speak of justice in health, we mean more than equal access to a clinic or a hospital bed. We mean a society in which structural injustices, those entrenched policies and economic orders that distribute risk and privilege unevenly, are acknowledged and addressed rather than left to perpetuate suffering. The historical record, from the sanitary reforms of Victorian cities to contemporary global health campaigns, shows that progress is possible, yet it also reminds us that progress requires persistent engagement with the deepest forces shaping life itself. Memory plays a dual role in this story. On the one hand, it preserves the lessons of past struggles, the protests for civil rights that demanded desegregation in medical institutions, the international declarations that elevated health as a moral right, the community movements that insisted on equitable care in the face of neglect and discrimination. These are not just historical landmarks, they are moral beacons, reminding us of what was fought for and what remains unwon. On the other hand, memory serves as a mirror, forcing us to confront episodes of medical exclusion, prejudice, and policy choices that overlooked or harmed entire populations, often in the name of efficiency or scientific authority. This dual function of memory, as both guide and warning, shapes how societies conceive future responsibilities. The future of health justice will necessarily grapple with new technologies, new social orders, and new forms of data. For example, as machine learning and artificial intelligence enter clinical decision-making and diagnostics, fierce debates have emerged about bias in algorithms, and the risk that these tools may perpetuate or deepen existing disparities unless governed by principles of fairness, transparency, and community engagement. Advocates such as civil rights organizations are now calling for equity-first standards in health technology, insisting that innovation must not come at the expense of the very populations that have historically endured neglect. These contemporary challenges illustrate a broader truth, that as medical science advances, the social dimensions of health must not be sidelined. The promise of new therapies and technologies should not blind societies to the fact that many people remain vulnerable because of the conditions that shape their everyday lives. In many regions today, unequal life expectancy, differential disease burden, and access gaps persist along lines of class, race, and place. These disparities are not random. They are symptoms of enduring social structures. Recognizing this does not diminish the value of scientific medicine. It places scientific achievement within a broader social context in which justice is part of the healing process itself. At the heart of an equitable vision of the future lies the notion that health is not merely a collection of outcomes to be managed clinically, but a site of human rights and collective choice. Policies that invest in early childhood, in equitable education, in safe labor conditions, and in fair distribution of resources are at least as consequential as the latest medical intervention. This is not a denial of medicine's technical achievements, but a recognition that medicine must serve human flourishing in a holistic sense, attentive to what shapes life before it enters the clinic doors. Memory also invites humility. To remember the past is to acknowledge that many battles for justice were only partially won, that progress has been uneven, and that old hierarchies often reinvent themselves in new forms. It invites future generations, clinicians, scholars, policymakers, and community members alike, to listen to diverse voices, especially those whose experiences have historically been marginalized. Such inclusion is not tokenism. It is a prerequisite for any genuine understanding of what health equity means in practice. In this spirit, the future of health justice is neither predetermined nor solely a matter of technological innovation. It is a collective project of societies that choose to align policy, ethics, and scientific understanding with a deep commitment to fairness. A commitment anchored in both memory of past struggles and imagination for what might yet be achieved. It is a future in which health is recognized as interwoven with equality of opportunity, dignity of the person, and the shared responsibility of communities. Thus, as this long narrative reaches its culmination, the scene returns to that scholar and the aged notebook. The pages are worn, yet they are alive with inquiry and aspiration. They remind us that medicine's history is not only about bodies and diseases, but about people striving for justice in how life and health are distributed. The past has taught that progress requires data and diagnosis as much as courage and conscience, that structures shape opportunity long before pathogens touch flesh, and that any future worthy of its name must address both the biological and the social determinants of health. The challenge now, and perhaps the imperative of our time, is to carry forward these lessons, to weave memory into policy, and to commit, in every generation, to health justice as a living promise rather than a distant ideal.